Welcome to the Ariel Precision Medicine Pancreatitis Facts and Fiction Follow-Up Discussion. This is Mark Haupt, Chief Medical Officer at Ariel. On April 1st, we recorded a webinar with the National Pancreas Foundation, during which Dr. David Whitcomb presented a lot of great information about pancreatitis, discussing topics from the role of alcohol and tobacco, as well as the role of genetic testing and risk factors for pancreatitis. You can find a recording of that webinar on our website in the resource section or on our YouTube page. In addition to the webinar, you will find a lot of great information about pancreatitis, and don't forget to check out our blog. Before and during the webinar, we received a lot of fantastic questions. While we did our best to answer them, we simply couldn't. So today, we have brought together a group of experts to answer your questions. Joining me today are Dr. David Whitcomb, professor of many things at the University of Pittsburgh and an international expert on the pancreas and founder of Ariel Precision Medicine. Celeste Shelton is a variant scientist at Ariel Precision Medicine, is also a certified genetic counselor, and has a PhD in human genetics. Katya Orlova is also a variant scientist at Ariel, is a certified genetic counselor, and has a master's in public health and is working on a PhD in genetics. Instead of a typical presentation, we hope this will be more of a discussion, so you can simply follow along and listen rather than following the slides. We do have some, and they're more so just to keep us organized. But with that, welcome everyone. We reviewed all of the questions we received, and they really broke down into the following categories. What are the various causes of pancreatitis? What are the complications of pancreatitis? There was a desire to learn more about the genetics of pancreatitis and why it's important to study them. To hear more about TPIATs, we'll get into the details of that. And lastly, what does COVID-19 mean for patients with pancreatitis, and what do we know about it? So let's dig in. Dr. Whitcomb, during our last webinar, you showed the slide that summarizes the Tiger-O classification scheme. And it seems like there's a lot of paths to get to a diagnosis of pancreatitis. And I also understand the scheme has been updated with the Tiger-O2 classification. Can you tell us how or what, with all these different causes, how does one arrive at a diagnosis of pancreatitis or a specific diagnosis? Where does it start? What's involved? And what does this typical journey look like?
Well, Mark, thank you for inviting me back to talk about some of these important questions. The issue of pancreatitis has to do with factors that injure the pancreas. And as you can imagine from everyday life, there are hundreds of different ways that you can have a bodily injury. So we have the same problem with the pancreas. What we have recognized is that sometimes there are 2 or 3 factors occurring at the same time that lead to pancreatic injury, where that factor alone will not cause pancreatitis. And we spend a lot of time talking about alcohol as an example, where only 1 or 2% of people who are heavy alcohol drinkers develop pancreatitis, and it's often those who also have underlying genetic disorders. What you see in this slide is a group of 7 different factors that have been found over the years to be associated with pancreatitis. And we use the acronym for the classification of Tiger-O, with T being toxic metabolic causes, I idiopathic, G genetics, A autoimmune, R recurrent and severe acute pancreatitis, and O for obstructive. And so whenever a person has acute pancreatitis, the doctor will go over this type of a list, either in their head or by checking a resource somewhere to understand what is causing pancreatitis or contributing to pancreatitis in the different cases. And so there are different tests that can be done to help zero in on many of these, with genetic testing being one of the most accurate and informative. So these are just a way for the doctor to organize these different causes. Now, the reason that's important is that you do not want this to happen again. And so if you can find the reason for injury in an individual person and the mechanism of injury, then the appropriate intervention is there. So for example, gallstones are very common cause of acute pancreatitis, where the bile in the gallbladder begins to form little stones, and the stones can come out of the gallbladder and go into the bile duct, which is the connection between the liver and the intestine. What's important from an anatomic standpoint is the pancreatic duct that takes the digestive enzymes from the inside of the pancreas to the intestine, joins the common bile duct, and they both enter the intestine through the same little area. And so if a gallstone comes down the common bile duct and gets stuck just before entering the intestine, then all of the pancreatic juices back up into the pancreas, and they can become activated so that the enzymes begin causing injury. So to prevent that, you can take out the gallbladder so that the stone formation ends, and then you don't have any more stones coming down to block the pancreatic duct, and the pancreatitis goes away.
Are there
In
patients?
alcoholism? Yeah, go ahead.
Dr. Whitcomb, that even if you take out the gallbladder, can they have recurrence of pancreatitis once that presumed risk factor is removed?
The answer is yes. What we've seen is that the likelihood that you have a recurrent attack of pancreatitis is markedly reduced, but there's some patients that continue to have recurrence even after their gallbladder is out. And many people who I'm sure are attending this webinar have had that experience where the likelihood was that the removal of the gallbladder would help, but in their case, it didn't.
Interesting. And you mentioned also, and we see up here, there's discussion of pancreas divisum or sphincter of Oddi dysfunction. What role do those two things play in pancreatitis?
Yeah, so those are under the obstructive, which on the Tiger O is the last one. And it's a very controversial area. For many years, it was believed that the sphincter of Oddi was important. And what that is a sphincter that regulates the release of bile and pancreatic juice into the intestine. So I mentioned there's two duct system, there's two little hoses that come, one from the liver and the other pancreas, joined together, and they don't just drip into the intestine. There's a sphincter that regulates the juice coming out and the intestinal contents not going backwards up into those organs, and that's the sphincter of Oddi. If that holds too tight, it was believed that both the bile and the pancreatic juice would back up into the organs and cause trouble. And so there was a lot of effort to use an ERCP to go and cut the sphincter in order to reduce the resistance to flow and have the juices flow quickly. But it turns out that it caused more pancreatitis than it prevented. And so we now believe that it's very rare that a sphincter of Oddi disorder will cause pancreatitis. That was a very important study where they took a number of patients, it was led by Peter Cotton, and found out that if you had a pretend cut versus a real cut, it made no difference. Likewise, pancreatic divisum is a condition in which the pancreas doesn't form quite right. Instead of one opening, it has two openings, and there's actually two parts of the pancreas that aren't connected to each other. It's like a double pancreas, and it is believed that the opening for the majority of the pancreas is too small, and that will cause pancreatitis. There's currently a study going on led by Dr. Greg Cote that is trying to answer the question about whether or not that actually causes pancreatitis or not. So there is a lot of interest in this because there is a potential treatment of doing therapeutic endoscopy but if it doesn't work, then we probably shouldn't do it.
And then we hear a lot about the immune system, and one of these categories listed here is autoimmune. What is autoimmune pancreatitis? And someone asked, are there genetic factors that lead to autoimmune pancreatitis?
That's another great question. And this is a disease that was really defined in Asia, especially Japan. And they found that a number of patients that they thought had pancreatic cancer, when they took out the pancreas, there was no cancer there, and it had an unusual type of inflammation. And they described this as autoimmune pancreatitis. And there are two types. Type 1, there's a blood test that is very informative. It's called an IgG4. And the other one, there's no real blood test for it, but it tends to happen in people with inflammatory bowel disease and pancreatitis and other autoimmune diseases. In this case, the pancreas just begins to get enlarged and stop functioning. And the reason it's important is that you want to make sure it's not happening because of cancer on one hand, but the other reason is that it is very responsive to treatment with steroids. So prednisone or some of these strong anti-inflammatories can actually cause this to reverse very rapidly. And so that is a diagnosis that's important to consider because there's a specific treatment for it. And so what we're beginning to show here is that for toxic metabolic causes, if you know what's causing the pancreatitis, you can treat it. If you have obstructive, you can treat it. If you have autoimmune, you can treat it. And now we're beginning to study genetics to find out how to best treat these disorders because they have to be compensated for. We do not have a way of changing the genetics, but we can hopefully bypass the effects.
That's great. So in your presentation, you had showed these images of the pancreas, and as we look at these going from left to right, what we're seeing is an increase in the lighter pink areas, which is fibrosis. And we received a few questions about having pancreatitis without any signs of fibrosis or changes on CT scans, or patients had questions about having pancreatic atrophy without evidence of fibrosis. Can you talk a little bit about the meaning of fibrosis and pancreatitis and what it means to not have evidence of fibrosis, and also what is the idea of pancreatic senescence or atrophy or changes with age?
So this is a very important area, and many doctors have different opinions about it, although I think the work that our group and others have done is beginning to bring some clarity. The problem with pancreatitis back in the many years ago was that it was very hard to diagnose without doing an operation. And with the development of the CAT scan and some other imaging, it was possible to see the pancreas and to identify patients that had scarring and calcifications, which are little pieces of calcium that form within the scar. And so it was easy to be able to use those images as a substitute for actually doing a biopsy. And there are studies that showed that the images that you got from a CAT scan or MRI correlated pretty well with the actual pathology if you took out a piece of the pancreas and looked at it under the microscope. However, it's not 100% accurate. And that's been a little bit of a problem because in the past, the definition of chronic pancreatitis relied on a CAT scan or an ERCP. What we have shown with the NAPS2 study is that the scarring is part of an immune response to injury, and it is like debris or the side effects of it. And it is not the actual injury to the pancreas itself. And so if you measure things like pancreatic function or pancreatic pain or development of diabetes, they don't correlate with the amount of fibrosis until the very end. And so there are also patients that have some fibrosis but don't have pancreatitis. And we see that in patients with long-standing diabetes, especially type 1, and also patients who are older, or if they have some other unusual diseases, they'll get some fibrosis without actually having pancreatitis. So the fibrosis itself is a special type of immune response, and not everybody has it. Atrophy occurs when you actually lose the cells that make the digestive enzymes. And with fibrosis, you lose those cells, but with atrophy, you lose the enzyme-making cells without the scarring. And there is an interesting correlation. If you've got some calcified stones, little stones throughout the pancreas in atrophy, then it's probably chronic pancreatitis. If you just have a small pancreas, it's hard to tell what it is. So we're still working on this. We're still learning how to actually define what each individual person has, because there are different things going on. There are immune responses causing scarring. There are nerve problems causing different types of pain. There's the cells that make insulin that have different levels of resistance to injury. And then there's the effect of the duct cells and the acinar cells. So each one of them has to be looked at independently. So to summarize, the scarring is a byproduct of a certain type of inflammation, and it often correlates with pancreatic damage, but not always. Secondly, is the diagnosis is usually made with imaging, such as a CAT scan, but they're not 100% accurate. So there are people whose pancreas is the right shape, but on biopsy, they actually have a lot of fibrosis that just doesn't show up. And thirdly, there is fibrosis without pancreatitis that can occur in diabetes or other disorders as well. So each of these has to be looked at individually. You can't measure one thing and assume you know everything else.
So it's complicated.
It's complicated, but not infinitely complicated. It's like any machine is, you have to have the owner's manual and have a way of looking at different parts to find out when it's not working.
Speaking of different parts and the potential complications, this was a slide that you showed that talked about the progression from an episode of acute pancreatitis to chronic pancreatitis, and that there are many different of the parts that you were just describing, the acinar cells, the islet cells. You can have dysfunction in these different parts. Part of this model that you show here on the bottom is the development of metaplasia, and then progressing to PDAC, or pancreatic cancer generically. Can you talk a little bit about that progression and that risk? That there were a number of questions about development of pancreatic cancer in the setting of pancreatitis.
Yeah, this is a very important area, and one that has really frustrated physicians and scientists for a long time, because once pancreatic cancer develops and starts spreading, you just the treatments are very difficult and not as effective as we would like. Before I talk about pancreatic cancer, this slide is useful. If you look at the bottom panel and see E, end-stage disease, you see fibrosis and sclerosis being part of a process related to the immune system and dysregulation of the immune system. And you can see that the cells that cause fibrosis are different than the acinar cell, they're different than the islet cells, they're different than the nerves, and they're different than the duct cells that seem to be linked with cancer. So there are several steps that have to occur to go from normal to pancreatic cancer. And the steps have not been very well defined, but we're beginning to understand what they are. What cancer is where some of the cells have actual changes in their genetics so that the information that's controlling the cells is different than normal, and it goes haywire and starts causing the cells to rapidly grow and rapidly divide and spread. The intermediate step between normal and cancer is called metaplasia. And so when you see metaplasia, you know that there's progression. Now, unfortunately, you have to look under the microscope, which means there has to be a biopsy. And we don't know which part of the pancreas to biopsy because it could happen anywhere. And so this is sort of invisible in most patients. What we need in order to get cancer is you have to have damage to the DNA so that it develops mutations. And in order to get damage, there has to be toxins and growth factors and those types of things that cause damage to DNA in the cells of the pancreas. And it turns out that this is what happens to cause acute pancreatitis and chronic pancreatitis. There's a lot of toxic things and growth factors that are bathing the cells during these processes. And so randomly, there are a few cells that will get some mutations in them. And what happens is that the body has some amazing machinery that goes and checks all the DNA to see if there's any problem with it. And if it finds a problem, it can actually repair it in order to make the DNA in the right sequence again, or it causes the cell to kill itself. And that's an important protection. Patients who have a defect in this DNA repair are more likely to get mutations just in the wrong genes at the wrong time. And when you get the combination of at least 7 or 8 mutations in one cell, then that cell can become metaplastic. It goes through the metaplasia stage and turns into pancreatic ductal adenocarcinoma, which spells PDAC, or it's also known as pancreatic cancer. So the patients with chronic pancreatitis, we know, have damage going on to their DNA all the time. The question is that can the body repair it, or are there additional problems so that it's not repaired, and then randomly some of the cells get the wrong mutations and you start developing cancer?
Interesting. Celeste, you've done a lot of work evaluating genes related to hereditary cancer risk and pancreatic cancer. Could you comment further on that, and who should get tested, and what kind of evaluations are available to look into that type of process?
Sure. So certainly some families do have a higher predisposition for certain cancers, such as pancreatic cancer. And furthermore, several genes have been associated with hereditary cancer predisposition syndromes that include an increased risk for pancreatic cancer. However, it's important to mention that although they increase the risk for pancreatic cancer, most individuals with a hereditary cancer syndrome that includes a risk for pancreatic cancer will not develop pancreatic cancer. And in most predisposition syndromes, that pancreatic cancer risk is less than 10%. So an example that many people are familiar with is hereditary breast and ovarian cancer syndrome. This is caused by harmful variants in the BRCA1 or 2 genes, also known as BRCA1 and BRCA2. And you may remember several years ago, Angelina Jolie really spread awareness about this syndrome by publicizing her genetic testing status and the decision to undergo risk-reducing surgery. And so individuals with hereditary breast and ovarian cancer syndrome do additionally have an increased risk for pancreatic cancer. That risk is approximately 5 to 10% in BRCA2 carriers. Now, generally, hereditary cancer genes that are associated with an increased risk for pancreatic cancer are not specific for pancreatic cancer. And therefore, families may present with a greater incidence of cancer than expected and specific cancers that are indicative of a specific gene or syndrome. It's really important to mention here, though, that a family history is really important regardless of an individual's genetic test results. And this can provide some insight for patients who do have pancreatitis and are concerned about their pancreatic cancer risk. So some families with hereditary cancer predisposition syndromes do have a greater risk for pancreatic cancer than others. And there are other families that have a higher than expected incidence of pancreatic cancer, but they don't have a specific identifiable genetic cause. These families may have what we call familial pancreatic cancer, and this is defined as 2 or more biologically related first-degree family members with pancreatic cancer in the absence of a hereditary predisposition syndrome. So first degree would mean a parent-child pair or 2 full siblings, both affected with pancreatic cancer. Now, in these familial pancreatic cancer families, up to 90% of individuals or of families don't have a specific identifiable genetic cause. And therefore, in these cases, we can estimate cancer risks based on the pattern of pancreatic cancer in the family and your relationship to those individuals. So for example, an individual with 1 or 2 first-degree family members with pancreatic cancer, the risk for pancreatic cancer is estimated to be about 4 to 7%. So this really is a complex process, and we believe that the complex interaction of different genetic and environmental factors really provides that contribution to pancreatic cancer risk here. Ultimately, individuals who are concerned about their pancreatic cancer risk should speak to their physician about ways to reduce their risk. And moreover, genetic counseling can help an individual understand their risk for pancreatic cancer based on both their personal and their family history, as well as determine eligibility for additional genetic testing for their cancer risk. There are several guidelines available to determine who may benefit from genetic testing for a hereditary cancer predisposition syndrome. So certainly individuals that may benefit include those with a personal or family history of pancreatic cancer, individuals with multiple cancers in the family, early onset cancer, individuals with multiple cancer primaries, and breast or prostate cancer in an individual with Ashkenazi Jewish ancestry, among others. During genetic counseling, a genetic counselor will review your personal and family history, and they can determine eligibility for genetic testing. There are several genetic tests available which can be challenging to navigate, and a genetic counselor is trained to choose the most appropriate genes to test for based on an individual's personal and family history. However, just because a person is eligible for genetic testing does not mean they necessarily have to get a genetic test. That the decision to pursue genetic testing is a highly personal decision, and a genetic counselor can provide information related to all aspects of that process to help a person make an informed choice. And furthermore, it's important to mention that genetic testing is always going to be the most informative in an affected individual. If an unaffected individual with a family history of cancer has genetic testing and nothing is identified, it's not clear if it's because there's a pathogenic variant in the family and they just didn't inherit it, or if there isn't an identifiable genetic cause and therefore the family history really needs to be taken into account here.
That's great. Thanks so much. I think we'll get back to more about the role of genetic counseling and the importance that genetic counselors play in identifying and interpreting and helping guide patients and practitioners through the genetic testing process and making sure that the appropriate information is conveyed and the right test is selected to answer the question at hand. So we're going to move on into a little bit of the complications of pancreatitis. And Dr. Whitcomb, I'm going to come back to you. This is something you had shown. We had a number of questions about maldigestion and pancreatic insufficiency. what is it? What causes it? Can we reverse it? Can we treat it? So I'd like to hear your thoughts on maldigestion and exocrine insufficiency briefly.
So maldigestion is a complicated problem. What it means is that some of the food that you're eating doesn't get digested in a normal way, and it causes signs and symptoms, which can be nausea, bloating, diarrhea, and often with maldigestion caused by pancreatic problems, there's oil in the stool, or the stool floats and it's hard to flush, and just very strong smell. So, but the maldigestion can be caused by many different things. If the maldigestion is caused by specifically a lack of pancreatic digestive enzymes, then it's called exocrine pancreatic insufficiency, or EPI. So the exocrine pancreatic insufficiency means that the pancreas is not responding appropriately to the stimulation that it gets after a meal. The pancreas is an amazing organ. It's a gland like your salivary gland that responds to acid in the intestine or some undigested food, and there is a signal that goes from the intestine to the pancreas telling it to secrete these digestive enzymes that then pour into the intestine and digest the meal. And when the meal is digested, then the signal to stimulate the pancreas goes away and the pancreas goes back to rest. Now, the amount of digestive enzymes that are needed depends on how big the meal is. It depends on what type of food is being eaten. So, for example, if a person eats something that's pure sugar, you don't need the pancreas to digest it, because the intestine has the enzymes and the transporters to move the sugar into the bloodstream directly. If the sugar is a complex carbohydrate, then the pancreas is needed, because the digestive enzymes inside of the pancreas really target complex things like complex carbohydrates, meats, and fats. And so if those are in the diet, then you need the pancreas. If you eat a small meal, you don't need very many enzymes. If you eat a large meal, you need a lot of enzymes. Now, we usually measure it by lipase levels, and the pancreas with a large meal can make 1 million units of lipase. And it turns out that you probably only need about 10% for your body to have the minimum amount it needs based on all the other adaptation that the intestines could do. So what we see is that as the pancreas is injured and is slowly damaged and replaced by fibrosis or by atrophy, the amount of enzymes start going down, down, down until it gets too low to do certain things. Often the first thing you see is the fat is not digested correctly. And we can see that because the patients will change their diet to have lower fat so they don't get the symptoms of it. But you also have the penalty of not being able to absorb fat-soluble vitamins like vitamin D and vitamin A and vitamin E. And the pancreas is also critical for absorbing vitamin B12. So the fact that a person is not able to digest their food and they switch away from a fat diet to a high carbohydrate diet means they can avoid the symptoms of maldigestion, but their body is suffering because just because you're eating sugar, you can still be overweight, but be severely malnourished when it comes to the proteins and the vitamins that your body needs. So the maldigestion occurs as the pancreas gets less and less ability to secrete enzymes. And instead of changing the diet to something that feels better to the patient, we really need to treat them with pancreatic enzyme replacement therapy, or PERT, so that you can actually digest the proteins that your body needs and digest the fats that the body needs, and also assist in the more complex carbohydrates. Now, as I said, it depends on a variety of things, how much of the pancreas is there, if you eat balanced meals or large meals, the size of the person, the diet they're on. And so all of these have to be taken into an account. But when the pancreas is destroyed to a certain level, it's just beyond what you can compensate for. And about 40% of patients with pancreatitis just reach such a severe stage that changing the diet doesn't help.
Great, thank you. Now one of the focus of our last talk and a few that we've given has really been on the genetics of pancreatitis, and that's obviously what we focus on at Ariel Precision Medicine. And so we're going to pivot now and start to talk about genetics of pancreatitis. And one of the concepts that's being brought up frequently in this space, as well as others with chronic disease, is complex disease genetics. So, Katya, you've shared this before and discussed the concept of a jar to talk about risk and genetics and environmental factors and complex disease. Could you walk us through this analogy?
Sure. Thanks, Mark. So complex disease is disease that results from a combination of both genetic and environmental risk factors. So on this slide, if you're looking at slides, you'll see that we can use a jar model to illustrate how these various risks can add up to cause a disease. The jar here represents a person, and the circles, or you can think of them as marbles, represent the genetic factors that can put you at higher risk of disease. And when the jar becomes full and overflows, that's when the disease happens. So different people are born with different amounts of genetic risk, and they have that genetic risk for life that can't be changed. In this case, Jason's jar has more genetic risk than Emily's jar. On the next slide, you'll see that you can also add the environmental risks represented by triangles to this jar, and they also contribute to filling up the jar to cause disease. So these environmental risks can include behavioral risks like drinking alcohol or smoking. And these environmental risks can add up over time to cause the jar to overflow, but they can also be removed. For example, if you quit smoking. Now, on this next slide, you'll see that Jason's jar has overflowed thanks to the extra environmental risk factors, and he is now affected by the disease, whereas Emily's risks are still below the disease threshold. So even though Jason and Emily had acquired the same number of environmental risk factors over time, the 5 triangles, only Jason's jar overflowed because he had more genetic risk from the beginning. And you'll notice that one of the reasons that Jason had more risk is because that some of his genetic risk factors were bigger in size than those of Emily's. On the next slide, you'll see an illustration of the fact that some genetic risks are bigger or more impactful than others in terms of potentially causing disease. And these we call pathogenic variants, which tend to be rare in the population and have strong effects. On the other hand, there's also smaller genetic risks called risk variants that have a lesser impact, but can have a large impact in aggregate or can modify disease symptoms. And at Ariel, we actually test for both of these types of genetic risks. Now, on the next slide, one thing to note is that right now we do not fully understand all of the environmental and genetic risk that can lead to pancreatitis. But scientific research is always moving forward to try to understand how genes and environment come together to cause disease. And we don't have all the answers yet, so scientists cannot 100% predict who will get disease and who will not, solely based on the genetics and the environment. But we can get some answers through genetic testing.
So one question that had come up, Katya, is that, you know, if you have a variant that is identified that's associated with pancreatitis, does that mean you get pancreatitis, or does not everyone who has a variant get the condition that's associated with that change?
That's a good question, and it comes up a lot. And the answer in part depends on what kind of genetic variant it is. So ones that are pathogenic, if let's say it's for a pathogenic variant for hereditary pancreatitis, there is an up to 80% chance that a person will get pancreatitis. On the other hand, if it's just a genetic risk variant or a few genetic risk variants, some of that depends on the environment that the person's exposed to, other genetic risk variants, genetic risk variants that we might not know exist yet. So solely based on the genetic risk variant presence, you can't necessarily say who will get a disease and who will not.
So this kind of goes back to the whole point of the importance of having the complete picture, the complete story, the family history, the medical history, the surgical history, medications, environmental factors, imaging, laboratory. Really, we have to put all those pieces together to truly understand why someone may or may not be affected and what it could mean for their families. Could you also explain a little bit about complex or multi-inheritance patterns?
Of course. So when we're thinking about complex genetic disease and how it travels through a family and how it's inherited, this is called a multifactorial inheritance pattern. So what that means is parents can have various amounts of these genetic risk variants and on different parts of their DNA. And when people have children, not all the DNA is passed on. So it's kind of a chance which parts of the DNA get passed on to which children. By chance, some of the kids can have higher concentrations of these risk variants, and their jar can be overflowing sooner than that of other children who by chance happen to inherit fewer of these variants. But this kind of speaks to how difficult it might be to predict risk to family members solely based on these lower impact risk variants alone. So as you said, that's where family history and a lot of the other factors come into play, like the importance of avoiding environmental risk factors like smoking and alcohol.
Great, thanks for clarifying that. One thing that we've mentioned, and something that has a large genetic component, is hereditary pancreatitis. Celeste, can you tell us about hereditary pancreatitis, why or how genetics may play a role in that? And we also hear about familial pancreatitis. What's the difference?
Sure. So hereditary pancreatitis is really distinct from what Katya was just speaking about in terms of complex genetics. Rather than being caused by multiple genes and different risk factors and environmental factors, hereditary pancreatitis is generally caused by a single known pathogenic variant in a specific gene, specifically the PRSS1 gene. It's clinically defined as 2 or more individuals with recurrent acute or chronic pancreatitis in 2 or more generations of a family. This is basically following an autosomal dominant inheritance pattern, or pancreatitis in the presence of a known pathogenic PRSS1 variant. Now, as you can see from this slide, it's showing time to symptom development for different symptoms of pancreatitis. It's showing age on the bottom and percent of patients at the age at which they develop that symptom. So as you can see, there's really significant variability in the time that an individual even experiences their first attack in the presence of a known pathogenic PRSS1 variant. The typical age of onset is between the ages of 10 and 12. But it can range from less than 1 year of age all the way to over 70 years. And furthermore, about 20% of individuals who have a pathogenic PRSS1 variant never have a clinically recognizable episode of pancreatitis. And it's really unclear why this is at the moment. And certainly researchers are currently working on trying to understand how other environmental and genetic risk contributions might be changing this risk in individuals and families. Individuals are also at risk to develop other complications of chronic pancreatitis, such as diabetes and pancreatic exocrine insufficiency, as you can see here. And as we discussed earlier, the most feared complication is this increased risk for pancreatic cancer, particularly after the age of 50. However, as we mentioned previously, different families seem to have different risks for pancreatic cancer, and we see some families with hereditary pancreatitis who have a larger incidence of individuals with pancreatic cancer, and then other large families with hereditary pancreatitis in which there's no one with pancreatic cancer. So it's really unclear why that is, and we're currently working on trying to understand how other factors might modify an individual or a family's severity and progression of disease and the risk for these different outcomes, such as pancreatic cancer. Now, you had mentioned familial pancreatitis, and this is really a great question because while hereditary pancreatitis refers to this autosomal dominant appearing pancreatitis in a family with a very specific single genetic cause, familial pancreatitis is really this broader term to describe a family with a greater incidence of pancreatitis than expected by chance. It's defined as 2 or more biologically related first or second degree individuals with pancreatitis in the absence of other causes such as gallstones, trauma, or heavy alcohol consumptions. So examples of first degree family members are parent, child, pairs, or siblings. And second degree would be grandparent, grandchild pairs, aunt and uncle, and niece and nephews, and also half siblings. Now, families with familial pancreatitis tend to have recessive or more complex phenotypes in the absence of a clear syndrome, such as cystic fibrosis. So known genetic contributors include low to moderate penetrance risk variants in several different genes, such as SPINK1 or CFTR. And many families have multiple variants that each confer a small risk on their own, but together really significantly increase the risk for pancreatitis. And this was really well explained by Katya with the JAR model.
That's great, thanks. And didn't mean to move the slide too early, my apology.
Mark?
Yes,
Go
ahead.
Celeste got her PhD working on this. And this slide I see is one from about 15 years ago, a big study that came out of Europe, and it shows this high risk of pancreatic cancer. Perhaps Dr. Shelton would be useful for just mentioning what you found in the studies of the patients in America that had been followed for up to 20 years.
Yeah, so that was a really reassuring finding by looking at individuals in the United States with really this more broad inclusion criteria so that we would capture not only individuals with very severe courses of hereditary pancreatitis, but other families that may have a more mild clinical course. We're able to find that the risk for pancreatic cancer in America is closer to 7.2% at the age of 70 years. And this is very different from some of the original studies that had originally estimated a 40% risk at age 70, which of course, that's a huge difference. We find this to be very reassuring. And we've also seen, and this isn't really well published yet, that different families appear to have different risks for pancreatic cancer. So I would definitely say that although an individual with hereditary pancreatitis certainly has an increased risk for pancreatic cancer, family history really needs to be taken into account to truly determine and modify that individual's risk. And it's certainly going to be more concerning in a family in which there are other individuals with hereditary pancreatitis living long lives who develop pancreatic cancer versus another family in which individuals are also living very, very long lives with hereditary pancreatitis, but not developing pancreatic cancer.
Another finding was that back 30 years ago, this rate of smoking was very, very high. Mm-hmm. We found that you could reduce the risk by not smoking, and the current generations, I believe the smoking rate is much lower as well, and perhaps the warning to stop smoking also helped reduce the rate of pancreatic cancer from 40% to far less than 10%.
That's a great clarification. I think it also shows how much we're continuing to learn and understand what are all the different elements that go into these diseases, and how to understand within the context of not only each individual, within each family, and within the population as well. So great discussion there. Dr. Whitcomb, Celeste had mentioned that PRSS1 was a variance in PRSS1 are associated with hereditary pancreatitis, and it's obviously associated with trypsin. Can you tell us really briefly why trypsin is important in pancreatitis, and why it's important to understand perhaps the more global trypsin pathway and how that relates to pancreatitis?
Yeah, first of all, we've been talking about PRSS1. PRSS1 is the gene that makes trypsin. Trypsin is the most important digestive enzyme, so that is like a biological scissor that cuts proteins. And trypsin is one that is a very aggressive and powerful enzyme that can cut proteins very effectively. But it also has another role, and it is amazing to me that with an organ that's called pancreas, which means all meat. The majority of the digestive enzymes are protein digestive enzymes, and yet the pancreas normally doesn't digest itself. And the reason is that the acinar cells, shown at the top of the cluster, that make the digestive enzymes, and that's their primary purpose, make them in inactive forms, so they don't work. The key is they have an on-off switch, and the switch is turned on by trypsin. So if trypsin accidentally gets turned on, it turns on all the other digestive enzymes, and the enzymes turn on the cells that made them and begin just chewing through the cells and digesting them and causing intense inflammation. So trypsin is very important. Now, in normal physiology, when the inactive form of trypsin, called trypsinogen, gets into the intestine, there is a special enzyme that turns on trypsin by changing the trypsinogen to trypsin. And interestingly, it was discovered by Pavlov with his Pavlov dogs, and he discovered that. And so normally the activation occurs inside of the intestine, where the lining of the intestine is protected from trypsin, but the food inside is not, so it gets digested. So any time that the trypsin gets stuck inside of the acinar cell and digested, it causes trouble. If it is in the duct cells flush the trypsin out by squirting fluid into that cul-de-sac, so the fluid can only go one direction, and that's down into the intestine. And if the duct gets blocked by a gallstone, we talked about earlier, or other factors, then the trypsin can't get out, and it can become activated and cause so much damage. And so trypsin is the key enzyme because it turns on all the other digestive enzymes and changes the pancreatic enzymes in the pancreas from an inactive form to an active form, which causes digestion of the pancreas and intense inflammation.
So is this a little bit of the regulation you're talking about? How do CTRC and SPINK1 get involved with this, and why are they important?
Yeah, so the body is made with at least 10 different ways of protecting itself from trypsin. It's made, as I mentioned, inside the cell in an inactive form, but it's also packaged in a very condensed package that makes it almost impossible to activate trypsin inside those packages. The site of activation is in the intestine, and we talked about that as well. The duct cells also are important in protecting trypsin, but that is a way that normally protects it. If trypsin does become active, then there are two ways to immediately shut it off. The first one is CTRC, shown on the right. This is another digestive enzyme, but what it normally does is digest trypsin. And you can see that with the CTRC present, the trypsin is self-digested. If there is ongoing inflammation or injury, then the body turns on the production of another protein called SPINK1. It's also called the pancreatic secretory trypsin inhibitor. And the level goes from almost undetectable to several times higher than the total amount of trypsin under normal circumstances, and can just shut trypsin down. If you think about trypsin as a Pac-Man with a mouth on it, it sticks inside the mouth, the spink sticks inside of the mouth and blocks it, so that trypsin bites onto the spink and can't let go and and spink can't be released, so it just permanently inhibits that. There's other things that are important, like calcium, which also turns trypsin on and off by regulating itself. And so keeping the calcium levels low is also important inside the pancreas in order to stop trypsin becoming activated. So there are a number of different ways that can cause pancreatitis, but they all seem to focus on trypsin and the trypsinogen pathway for acute pancreatitis. So gallstones can lead to pancreatitis. The calcium being too high, caused by stimulating the pancreas too much or drinking alcohol, can cause trypsin to be more easily activated. And then failure to destroy trypsin with CTRC variants or with SPINK not being upregulated or formed the normal way. These are some of the ways that are important for causing pancreatitis that normally is controlled by one of the systems that the body has to protect itself.
So it seems there's a lot of different pieces or elements of this that could potentially go wrong, and that perhaps different variants in the genes that are related to these processes can go awry. So Celeste, we've shown this chart before, and we've got all these different genes that are listed on the left side, and then all these different pathways and processes listed across the top. But what does this really mean, and how does this relate to what we've been talking about with complex genetics? And are these things that we can look at to evaluate someone's potential risk for pancreatitis? If you could walk us through this a little bit, that'd be great.
Sure. So these definitely are genes that have been associated with risk for pancreatitis that we can look at to further refine an individual's risk for pancreatitis, as well as what may have caused their pancreatitis if they are affected. And we can subclassify these genes based on where they function in the pancreas and how they contribute to that development of pancreatitis. Several genes work in the trypsin pathway, as Dr. Whitcomb explained, and here you're showing trypsin activity and also trypsin regulation. So trypsin regulation would include the SPINK1 gene that Dr. Whitcomb spoke about. This is a protective protein that protects against prematurely active trypsin in the pancreas. And variants that cause SPINK1 to lose its function reduce a person's protection against pancreatic damage from the trypsin pathway. Other pathways also impact risk. For example, variants in CFTR and CASR may reduce the ability of the pancreatic duct to efficiently flush those enzymes out of the pancreas and into the small intestine. And this leaves the pancreas vulnerable to those enzymes that are sitting in the pancreas for a longer period of time. Now, other cellular pathways can also contribute to pancreatitis. Here we're showing the endoplasmic reticulum stress response and also oxidative stress. And these different stress responses can lead to inflammation and possibly pancreatitis. The first, endoplasmic reticulum stress, or ER stress, can be caused by proteins that don't fold properly due to different genetic variants. So instead of performing their function, these proteins then collect in a cell, leading to this stress response. Oxidative stress is the overwhelming presence of reactive oxygen species, more than the antioxidant defenses can control, and genetic variants in alcohol can contribute to oxidative stress. Ultimately, the important point is that dysfunction in these different important biological pathways may promote inflammation and tissue damage, and if there is enough dysfunction to get to that point, they may result in pancreatitis.
That's great. So, Dr. Whitcomb, we've seen recently some various academic societies and papers coming out in the scientific literature suggesting that evaluating genetic factors is important or necessary in the evaluation of individuals of pancreatitis. Why should a patient get genetic testing, and how does it help? What can it show? Because it seems like it's a lot of information, but how does it get to the patient, and why is it important?
So that's a really important thing, and this is showing the progression of the entire field and a change of the entire field. Back when I trained, I was taught that if you see pancreatitis, it's either alcohol or obstruction. And so if a person wasn't alcoholic and they kept having pancreatitis, then an ERCP was done in order to find obstruction, and they got pancreatitis again, and they got another ERCP. And there are patients that have had 30 to 40 ERCPs because the doctor was just taught either alcoholic or they have an obstruction. Well, what this says is that as soon as the patient is found not to have a gallstone, and by history they're not a heavy alcoholic, then it's important to find out what's actually causing this. So with a single test that covers all of these genes, we can pinpoint the actual underlying problem that may be leading to the recurrent pancreatitis. The reason that's important is that Dr. Shelton pointed out there are completely different ways in which these mutations can cause disease, but we have ways of treating that. We can begin targeting therapy based on what the underlying problem is. And now that we can sort the patients out, we will be needing to do some trials to find out if these specialized therapies are going to work, and who should get which treatment at what time, so they don't have to have a long odyssey of diagnostic tests. They don't have to have repeated CAT scans and ERCPs. They can be treated the right way the first time. They know what medicines they should be on and can have a productive life.
Katya, what's your perspective on this? You talked about the complex and multifactorial inheritance, but what do you think about these different pathways and how all of this comes together?
Whoops, sorry, I was on mute. I think identifying genetic variants and potentially a genetic cause for a disease beyond just helping point somebody to a particular direction can potentially help a person cope with having the disease if they have kind of like an answer for a reason or part of the reason why they may have the symptoms that they do. And with that, they can go and find other people who are similarly affected online or in person in support groups. Depending on the variant found, you can also help family members understand the risk of their disease. So if a more high impact variant is identified, other family members can get tested for it. And of course, as Dr. Whitcomb said, apart from management changes that can occur, people who have certain variants identified may be eligible for clinical trials for new therapies.
Great. Thanks, everyone. Dave, and one thing that has come up in this talk has been mentioned a number of times is CFTR and its role in flushing out the pancreatic duct and its potential role in pancreatitis. But can you tell us, what is CFTR? What role does it have with pancreatitis? If someone has a CFTR variant, does that mean they have cystic fibrosis? And if someone gets testing for pancreatitis and a CFTR variant is identified, what happens next, or what should happen next, in your opinion?
So CFTR is a fascinating molecule. It's like a faucet. And if you have a faucet in your sink and you turn twist the handle on, water comes flowing out until you turn it and it shuts it off again. And actually, that's what cystic fibrosis does. It does it a little bit indirectly because the water doesn't come through the channel itself. Just chloride or bicarbonate ions do, and then by osmosis, it causes fluid to come rushing into the duct cell, in the case of the pancreas, to flush the trypsin out. And so the main molecule in the pancreatic duct is this CFTR. Now, the molecule is used in many different organs in the body. And so if a person has a mutation, they have, first of all, destruction of the pancreas because none of the digestive enzymes can come out, and that happens early in life. Later, they can have lung problems and liver problems and intestinal problems because those organs have some ability to compensate for not having CFTR. But in the pancreas, it is a critical molecule. Now, it is a recessive disease. Your body has two CFTR copies. And so if you have just one, you can limp by doing okay. If there's damage to two copies, if both are affected, then your body cannot compensate for that. It turns out that the most common CFTR variant, the F508 delete, or Delta F508, is very common, and it's a severe mutation. But there are hundreds of additional variants that can be severely damaging or only mildly damaging. And so some individuals will have complete destruction of one type of molecule and partial of the other. So there's a little bit of function that's still possible, and they'll have a milder form of cystic fibrosis. Now, the diagram shown on this slide shows the amount of function that the CFTR has on the bottom. And you can see that if you have 100% of function, there's no effects. On the far right, there's no problem. But as the amount of total function goes to 50%, then you don't have cystic fibrosis, but you're at risk for pancreatitis. And when you get down to only about 10% of function, then the pancreas is completely destroyed, and you have chronic pancreatitis from infancy and not risk of attacks of pancreatitis. And so the amount of function that is left in the pancreas, if it's a moderate amount of function, then you're at risk for recurrent acute pancreatitis. If it is completely lost, then you have chronic pancreatitis. If you have above about 75% function, then you may have pancreatitis from something else, but it's unlikely due to the cystic fibrosis gene. So it's kind of a complicated diagram is shown here. And so from a practical standpoint, people that are variant experts like Katya and Celeste can look at the combination of genetic variants, track it back to known functions, and then make a recommendation. And the best thing to do is to have a sweat chloride test, because that is a direct measure of how well that cystic fibrosis gene actually works and whether or not it is making enough CFTR to actually function. And so we use this test as a direct measure, which is important because it can also direct therapy.
Are there some cases, Dr. Whitcomb, in which, or variants, I should say, in CFTR, in which the sweat chloride test measures chloride, but are there variants in CFTR that have been shown to be associated with pancreatitis that maybe you wouldn't have an abnormal sweat chloride test?
Yeah, so that's important for two reasons. First of all, the sweat chloride test is not a perfect test. There's a little bit of variability. And so that's why for confirming cystic fibrosis, sometimes it'll be repeated 2 or 3 times in order to get a consistent finding. Secondly, is that the sweat chloride test measures chloride. The pancreas does not use CFTR to secrete chloride. It uses CFTR to secrete bicarbonate, which is a larger, more complicated molecule. And we discovered that this CFTR molecule is able to switch from a chloride secreting molecule to a bicarbonate one through a very sophisticated and fancy mechanism that's just recently been figured out. If that switch doesn't occur, then the pancreas is damaged because it can't make bicarbonate. But if you do a sweat chloride, it'll be normal because it can still secrete chloride. So those instances are less common, but that's one possibility. The second thing is that sometimes a single CFTR molecule that reduces pancreatic function a little bit or by say 50% if you're missing half of the CFTR function, that's enough to eke by unless you have another problem such as smoking or a SPINK1 variant or another gene, because it's part of a complex system. And so if the rest of the system is unable to compensate for CFTR damage, then you're at risk of pancreatitis.
Very interesting. So I think, again, it highlights the importance of looking at the total picture of a patient's history, their clinical symptoms, their family history, and shows that things like genetics as well as tests like sweat chloride are all a piece of the puzzle. And you need to have the right information and expertise and knowledge to really put that all together as both a clinician, a scientist, as well as with patients, genetic counselors, and other resources that are available to really understand how to help each individual. Speaking of helping, one of the number of questions we received is, can you reverse the function, restore the function of the pancreas? And what is a TPIT and how does it, what role does it play for chronic pancreatitis? And so, Dr. Whitcomb, I think we could probably spend a whole week talking about the role of TPIT and a lot of time on it, but in just a short amount of time, can you tell us what is a TPIT, what role does it have, what benefit may have, and who is it really indicated for, and how do you get to that?
Yeah, so first of all, there's some new guidelines that will be coming out from an international consortium of experts to really help physicians understand this, because it is a little bit complicated. It goes back to the question about whether or not the pancreatitis is reversible. And the answer is we believe it is. And what we were taught back when I was in medical school was that liver disease was irreversible. But now we know that with treatment of hepatitis C and with cessation of alcohol and smoking, liver disease that's partially destroying the liver can be reversed, but there's a point in time where it's too far gone. And we think the same thing is happening with the pancreas. Indeed, children with recurrent pancreatitis seem to have the ability to grow their pancreas back to normal. We don't know how that works. We're studying that, but there does seem to be a chance to regenerate. But there's a point in time when it's too late, especially if you can't remove the underlying cause. If the person has such bad genetics that their pancreas is being injured over and over and over again, now you start worrying about the islet cells that make insulin, because having chronic pancreatitis and diabetes is a very serious combination of factors. So it's possible to take the pancreas out, to remove the cells that make insulin, and then infuse them into the liver so that it can help control the blood sugar, even though the rest of the pancreas has been taken out and thrown in the garbage. So it's a way to protect the person from the damage of uncontrolled pancreatitis and yet keep them from becoming diabetic.
Wonderful. Thank you. And our last topic is obviously something top of mind for the world. And we've received a number of questions about what do we know about COVID-19 in the pancreas and pancreatitis patients, and what risks are associated with it. And, obviously, this is information about this virus and the impact it has on the body is changing daily, and it's a rapidly evolving field, and we continue to learn more and more and more. So, Katya, can you kind of summarize or what we know thus far? This was what we're showing here is a recent paper that came out looking at changes in lipase levels, which many of you will be familiar with in the pancreatitis world. But what do we know?
Sure. So recently this paper came out called Lipase Elevation in Patients with COVID-19 by the author Julia McNabb-Baltar and colleagues in Boston. And what this paper looked at was 71 COVID patients in the US. And they looked at differences in gastrointestinal symptoms and outcomes like going to the ICU or death, and differences in lipase levels. And lipase levels in the blood can mean that the pancreas is being injured. So what they found was that among the 71 COVID patients, about 9 or 12% of them developed elevated lipase levels. But thankfully, this was not associated with worse outcomes like intubation, death, or intensive care unit utilization. And there were not differences found in terms of gastrointestinal symptoms for those people, like nausea, anorexia, abdominal discomfort, and diarrhea. So there was the concern that potentially that elevation in lipase could mean that they'd be more likely to have pancreatitis, but at least in this small study, they did not find that there was an increased risk for pancreatitis. That being said, the research is still ongoing, so it's hard to draw too many heavy conclusions from this. And the doctor that patients are seeing is still probably the best person to talk to about COVID-19 and potential symptoms with respect to pancreatitis. The other things that we know about pancreatitis, or what people with pancreatitis might want to think about with respect to COVID, we have a pretty detailed blog post about it on our website. But to briefly summarize that, we've found that depending on the reason for pancreatitis, some patients might have some increased risk for severe COVID-19. And to back up a little, we know that most people with COVID-19 will have mild disease or even have no symptoms, but certain groups are at higher risk of developing the severe version of COVID-19. So people at higher risk for severe illness are those with older age, especially those 65 and older, those with high blood pressure, heart disease, diabetes, lung disease, those with impaired immune systems, and those affected by obesity. And so some patients with pancreatitis may fall into the higher risk group based on the reason why they have pancreatitis and various complications of pancreatitis that they may have. So, for example, pancreatitis that is a result of cystic fibrosis may result in increased risk of severe COVID-19, especially if there's lung disease present. And the Cystic Fibrosis Foundation actually has really great frequently asked questions online for people with CF regarding COVID-19. Pancreatitis patients with autoimmune causes of pancreatitis, they are treated with steroid therapy, which depresses the immune system, and that may also increase the risk for severe COVID-19. There's also some issues like diabetes and pancreatic cancer that may increase the risk of COVID-19. So for diabetes, it might be a good time to keep the diabetes extra well controlled. And of course, there's behaviors that anyone can take part in that increase the risk of severe COVID-19, not just pancreatitis patients, but smoking, using tobacco, and drinking alcohol all contribute to either lung disease, reduced lung capacity, or lowering immunity. And that can also go for smoking marijuana or vaping, and using opioids, only because people who use opioids opioids have an effect on the breathing and health of the lungs. And finally, there can be digestive symptoms of COVID-19, even in people without respiratory symptoms. So that can be something like lack of appetite, diarrhea, vomiting, abdominal pain, changes in a person's smell and taste. And some of these overlap with symptoms of pancreatitis. So it's impossible to just be aware of that. And if there's any concern, to talk to the doctor. So overall, I think there's just some common sense precautions that patients can take with respect to social distancing and washing hands frequently. And of course, following guidelines of released by the Centers for Disease Control and Prevention.
Great, thank you, Katya.
And one other thing, the CDC actually also came out with guidance regarding medication. So anyone who's taking medication is recommended to get extra medications in case you have to stay for a prolonged period at home or any reasons like that.
It's a great practical tip. As Katya mentioned, we do have a blog post on our website about it. The Guts Charity UK website has some great information about COVID and patients with intestinal disorders, and obviously the CDC as well as your local officials are great resources to see where you can access help and other resources to stay as healthy as possible. With that, that's the end of our chat today, I would like to remind everyone that if you have specific questions about your health condition, the information provided in this does not replace that of your medical provider, and you should contact them with any specific questions. But we do hope the information we provided was useful to you. And we encourage you to reach out to us. You can email us at contact@arielmedicine.com with other ideas or topics for webinars that you'd like to see in the future. We do plan on diving into some of these details in the future, but really wanted to make sure we addressed the questions that were brought to us for the webinar we recently did with the National Pancreas Foundation. Always please feel free to reach out with questions. You can follow us on the various social media platforms where we post new information, updates about blog posts, as well as information in the community in general. And I would really like to thank our guests today, Dr. David Whitcomb, Celeste Shelton, and Katya Orlova for the discussion and going through a lot of information. And so we look forward to further discussions and providing more information about not only the work we're doing, but the pancreas community in general. And thanks for listening.